Dr. Julius Xatse is my guest today on the podcast. Doc, good to have you on the show.
Good to be here as well.
And to set the scene for the conversation, can you tell us a bit of what you do and what role it plays in mental health?
Okay. So I'm a psychiatrist. And being a psychiatrist, it means I'm a doctor who has had further training when it comes to the area of mental health. And so I'm able to help people with all sorts of mental health conditions. People who are seeking mental wellness, which means people don't even have to be mentally disordered before I can also be of assistance and help to them. And I see and attend to the entire range of people with mental health issues, from substance to the very severe forms of psychosis like schizophrenia, even bipolar and the rest, depression, anxiety and the rest, just name it. And I can be there and I take care of all these kind of people.
And looking back, is this something you were passionate about, something you always wanted to do growing up, going to the medical school?
Well, looking back, if I cast my mind back a little bit, I think I found myself living in a psychiatric hospital my entire life. My mom was a psychiatric nurse, or a mental health nurse for that matter. And we lived at Pantan Hospital. And in those days, patients used to roam about in the hospital throughout. I fraternized with them. Some of them knew me. They can call me from afar. And we can have some very nice conversations. So I practically grew up around people who I saw to suffer from one form of mental ailment or the other. And for me, I wasn't scared of that stigma that other people often face, to say that if you work or live around people with mental illnesses, then you are likely to also develop a mental illness in the future. But I've seen that to be totally false. It holds no truth at all. I think that being a mental health practitioner, and for that matter a psychiatrist, is a very high calling. And it takes people who are very matured in their way of thinking to commit themselves to help such vulnerable persons in the society. I think one of these very popular guys once said that a society should not be measured by how much riches they are able to display, but rather the amount of help or the helping hand we extend to the vulnerable in our society. And mentally ill people or patients are one of the people who are vulnerable, and we should pay attention to them as a nation or as a people. And that is how we should measure our wealth.
And how has your perspective evolved since you began the practice of mental health?
So it's not been easy. It's not been an easy journey throughout, because here is the passion, and this is the resource that is available to you to be able to deliver. And the question is, the people that you are even looking at reaching out to what extent are they able to even access the kind of service that you are willing to offer them? There are so many barriers when you look at the pathway to the care of mentally ill patients in this particular country, Ghana, and one of them primarily has to do with the financial barrier. I find myself to work in a tertiary psychiatric facility, and trust you me, even though we say that mental health care services are supposed to be free by the law, it takes something to make it free, which is resources, which is funding. And as I speak to you now, the country Ghana, we have no dedicated funding for mental health care services as a country, which means that the government has to always commit a certain portion of its budget that is possibly meant for something else to mental health care service. And you can trust that when the need arises that they are hard pressed, there will be a slash of how much will go into mental health care services. So the main barrier that I have faced, and what has shaped my perception, and also, should I say, is motivating me to even drive further and advocate for persons with mental illness, is this financial barrier that they face all the time. I've realized that if we are able to breach that barrier, we can reach out to more people in the communities, not just at the hospital per se, to make the mental health care services more accessible to them. Yeah.
So this financial burden, do you think it's only the responsibility of the state or private sector, or even at the individual level? Individuals also have responsibility towards, contributing some finances into mental health.
Yeah. So yes, it is true. When it comes to the financial barrier to mental health care services, it's something that not one person can solve. Government can do its bit, can do a very good portion of it.
At the state level,
yes, at the state level, by, for instance, passing the mental health levy for us to get dedicated funding for taking care of people who suffer mental health disorders. That is one aspect of it. But you and I also have to come on board, because when we are looking at mental health, it is not just individualistic, it is a societal thing. The entire society has to be mentally healthy. And who are the people who make up that society? It is you, it is me. So if I take care of you, and I am concerned about your mental health by, for instance, maybe providing you with some form of resources just to make sure I meet your need, it's going to go a very long way to give you some form of calmness, some soothing effect on your brain and on your thinking. So I think that society has to come together to help each other so that we can push and drive mental health forward to the level that we all expect it to be, because it is at the core of our development as a people. It is at the background of every aspect of our health, of our economy for that matter. You have no idea how much we lose as a country to mental health care services just because we are not paying attention to it. We have much more to gain if we pay more attention to mental health care services than even investing into it. So it doesn't matter. You don't have to have it all, just the little you may have. For instance, people could have 1 bag of rice here, 2 bags of rice here, and they can bring it on board to the mental health facility, and we use it to help other patients who cannot afford the services, and they receive the healthcare service for free, the mental health care service for free. And it goes a long way to even increase the productivity of the nation as a whole. To the extent that some of them have been repatriated home. Some of the people that you possibly are seeing in the streets, you refer to them as vagrants. As it stands now, we have treated them and we have put repatriation plans in place. They have been sent home. Some of them are working and are contributing to their families, taking care of other people's needs. And this is a huge achievement. And we can do that on a bigger scale if everybody comes on board and puts all hands on deck.
So if you are to mention the challenges, you've touched on financial challenges. Are there any other challenges aside the financial challenges? And if you can throw more light on specifically what the finances come to help, is it into infrastructure? Is it into providing more human resource? What exactly are the challenges?
Okay, so usually people say when you are talking about challenges and you start with financial challenges, you may forget about every other thing, because money seems to be the underlying
Yeah,
factor
it solves everything.
and
Yeah,
solves
of it,
almost
yeah.
everything. The Bible says it that money answereth all things,
Yeah.
you know, and that is the truth. We need these monies to, one, develop the infrastructure that is existing currently in the tertiary psychiatric hospitals. Most of them are very old. Accra Psychiatric Hospital is 120 years old. Ankaful Psychiatric Hospital is 60 years old. To this year, to 2025, is when Ankaful Psychiatric Hospital is celebrating its 60th anniversary. Pantan Hospital is 50 years old. So you can imagine every brick, every roof, every wood that exists in these facilities is that old. 50,
Yeah.
60, 120 years old. It may not be in the right shape. They may not be in the right form to sustain the weather conditions that they've been through.
Yeah.
And so they need a certain touch, and that requires some funding.
Yeah.
Now, that aside, we need funding for primary healthcare, primary mental health care for that matter. And this includes things like mental health promotion activities, because that is where you can put preventive measures in place to prevent people from developing the full-blown and overt mental illnesses that will get them on the street. We don't need to allow them to get to that level before we start treating them. But once we have the necessary funding, and we are doing educational programs for school children with regards to mental health disorders, we are doing educational programs on prevention of drug and substance abuse. It's going to go a long way to prevent and reduce the number of people who will grow up to become addicts, or people who grow up to have various forms of mental illnesses. And that means that it's going to cut the burden that will, for instance, come back onto society, because once they get there, they are totally dependent on society, and they cannot almost not add anything else to society until society goes in, spend huge sums of money to treat them, rehabilitate them, for them to get better before we reintegrate them at the end of the day. So we say prevention is better than cure. So health promotion activity is one huge thing that is also on the list. Now, another thing is the stigma. The stigma that people with mental illnesses face and experience, it is just choking. One would think that we are in a modern world, a global village. Everybody understands that mental illness or mental well-being is not a preserve of a few people, or it's not just for the elite. But people still have and talk about their mental health issues, and they feel stigmatized against. People laugh at them, people ridicule them, people look at them with some way. Sometimes they may not say it, but even the non-verbal reactions to people talking about their mental well-being alone goes long way for the individual to feel and experience the stigma that I'm talking about. And this is killing. And this is something that it is only education and normalizing mental illnesses in our society can solve. And we all need to come on board to do that particular aspect. Of course, we need some funding here and there. We will need for instance, genius people like this platform to talk about mental health issues, to make sure that the knowledge gets out there. It comes to people's doorsteps so that they can pass it on to their children, and then the society becomes a norm in our society for everybody to hold on to that idea.
So Doc, talking about mental health, I don't know if literature has any findings in how it is presented in the Western settings versus our cultural settings. If you compare the Western world and the African setting, is there any difference in perspective of how they anything about mental health. It can be even, for example, the stigma you mentioned, how they perceive it versus how we perceive it.
The funny thing is that when it comes to stigma in and mental health issues, it's almost the same
It cuts
throughout.
across.
It cuts across.
Oh, okay.
The white man also stigmatizes people with mental health disorders. Yes, they do that very much. So it's not something that is peculiar to us. So in the field or in the space of mental health issues, we are almost at par. Just that in the Western world, rules, laws, regulations seem to work a bit more. So you get it in a more subtle form compared to over here, where people can be bold and ridicule people on air or ridicule people even behind the pulpit when they talk about their mental health issues. You understand? But out there in the West, you may not get that happening in public like that. But there are the undertones. They still exist. But when it comes to the manifestation of mental illnesses or disorders, yes, usually the symptoms often take the shape or form of the norms of society or culture, for that matter. So, for instance, when it comes to Ghana, if I'm having any delusions or paranoia, it's most likely going to be delusions of somebody maybe poisoning me, or a witch trying to strangle me at night, or some my hometown villages they are watching me in a mirror,
all kinds of
misfortunes. But the white man with that same paranoia may possibly manifest it as maybe some aliens are coming through the space to come and catch him, or possibly they are monitoring him through his or her mobile phone, and they can they can communicate with him through some telepathic abilities. So you realize that it's more of the level of development of the society that we feed on when it comes to our symptomatology that we develop in mental illness. So even in Ghana, we are seeing it at the clinic. We see it. So somebody maybe from East Legon having delusions of persecutions or paranoia may, for instance, manifest it different from somebody who is from, Choko, excuse me to say, Choko, Teshi, or wherever it is, and has no idea about these kind of video games and things like that, you know. So yes, culture, religion, lifestyle plays into the symptomatology of mental illnesses most of the time.
Okay. Well, that's very interesting. Thank you so much for giving us a good background to get us into the bigger conversation, because these days almost everyone you talk to has experienced depression or is going through some kind of depression. And there's also a question as to people being able to differentiate between what anxiety is and what depression is. So in context, when we say depression or a person is depressed, what does it mean?
Wow. So depression is a very common term that we often use, and I hear a lot of people talk about depression as though it is all about feeling sad, losing a loved one, or something bad happening to an individual, like they've lost a job, and then all of a sudden they are sad, people are describing them as, oh, he's depressed, she's depressed. But depression actually goes beyond that, especially when we talk about it in terms of mental health disorders. Depression is actually a disease. It's a disease of the brain, for that matter, which often will manifest itself sometimes as the sadness we often refer to. But most of the time, the sadness may not even be there. The individual may not even be aware they are sad. Sometimes it manifests itself as this fatigue that the person does not know where it is coming from. whereby they are feeling almost always tired. Even after they sleep and they wake up in the morning, they feel tired, as though they didn't even sleep at all. And so you realize that sometimes they will continue to stay in bed for a very long time
than usual.
And they start becoming late to work. Their productivity will start dwindling. The people that they used to mingle with, they may not want to get close to them again. And so they start withdrawing socially. Then it can go on to the extent that they even may not want to eat as much as they used to eat. And then you realize that they start losing some weight. But ultimately, it boils down to the person who is experiencing the depressive symptoms actually having that subjective sense of low energy levels. You realize that the energy that they used to have, it will not be there again. It often goes that low that they feel that even sometimes talking to somebody is so much work that they would rather just keep quiet. And so that's why they don't want to come close to people. They would rather just lock themselves in the room and lie on the bed whilst they are thinking. And so they enter into those thinking loops, and at the end of the day they find it difficult to even concentrate on something. And so they pick a Bible. They can read the same sentence over and over again because the brain is not processing the information. The brain is not understanding what they are reading, and so the information is not going. They can't even move to the next sentence. So the brain will say, okay, read it again. They read it again, it still doesn't go. They read it again. So that lack of concentration is also one of the symptoms that people with depression manifest. But when we allow depression to go on for a very, very long time.
How long is a very long time?
It could go on for years. Sometimes, yes. It can go on for very long time. But ideally, it's supposed to be an episode. But some people get it for a very long time, 3 years, 4 years, 5 years, if it is not treated.
So what's the duration or the length of an episode, a regular or normal episode of depression?
It's variable. It's very variable. It like I said, it can range from 2 weeks to years.
2 years, okay.
2 years. Sometimes the episode may resolve, maybe after 3 months, 6 months may resolve. But without the necessary measures put in place, then it can come up again. So in a more recurrent form of it, you understand?
So is it to say that if it's regular sadness or an anxiety, it shouldn't travel beyond even 2 weeks or 3 weeks or a month?
Yeah, so usually if it is just about
being sad
or for instance somebody who is grieving, we don't expect it to go beyond like
a certain period, 2 weeks.
And the intensity should not be that intense to the point whereby some thoughts like why am I even still alive?
Suicide.
What is the essence of life? Those kind of things should not start coming to people's mind. Once it starts getting there, means the individual is getting to the extremes of it, and that's, for that matter, they need some form of assistance to be able to navigate the grieving period successfully.
So clinically, how are you able to measure depression clinically? If a person comes to your facility, how are you able to tell that this is depression?
Okay. So thank you for this question. I think it's a good opportunity to demystify what we do in the clinic as psychiatrists. Because I've seen and interviewed people at various points in time and made the diagnosis of maybe severe or major depression. And they asked me, doctor, what test did you do to say that I'm depressed? The truth is that there's no laboratory test to actually say that this person is having depression or not. Okay. But we have a set of criteria which we have investigated over the years, and we are able to tell based on the pattern of symptoms that the person may present with, to know that okay, this person, they are most likely suffering from a depressive disorder. But apart from that, there are some what we call instruments, psychometric instruments, skills, that have gone through rigorous research to identify how valid they are and how reliable they are, to be able to also identify even the level of severity of depression, and possibly to track the symptoms that people often manifest.
So these are physical manifestations.
Yes.
That's what you mean by psychometric.
Yeah, so psychometric because of the fact that they are measures.
Okay.
They are ways to measure
parameters,
the parameters or the symptoms of depression. That's why we refer to them as psychometric skills or instruments, for that matter.
What are some of these?
Oh, well, there is the Beck's depression inventory.
So these are the skills.
Yes, these are skills and tools, and there are a lot of them. I don't want to promote.
So what are the standards? What do you use in Ghana?
In Ghana, we have what we call the International Classification of Diseases. Currently, we are using 11, the 11th edition. Yes, and this is a WHO manual, which has the constellation of symptoms coming together to show that any particular person has this kind of disease or the other. So that's ICD, or International Classification of Diseases, I'm talking about. It doesn't only contain mental illnesses. There are other illnesses which are in that particular manual, which has symptoms that the whole world seems to have agreed that once you have this group of symptoms, it means that you most likely are having this disorder or that disorder. And depression is one of them. Yeah, for that matter.
So what are some of these symptoms
in the ICD?
Yeah. Maybe if not all, the major ones.
The major ones,
that people can easily relate to.
Okay, so in the ICD, we talk about 3 core symptoms, which are 1, the low mood, then decrease levels of energy, which I spoke about earlier on. So the person feeling sad, they are down, is accounting for the low moods. And then the decreased energy, whereby they don't want to get up, they don't want to do anything for themselves, also comes in. Yeah. I think there's a third one. What did I think I mentioned it along the way. It seems to have escaped me now. Yeah. There's something I wanted to talk about. It seemed to have maybe along the way when it comes, come back. I'll mention it. But these 3 core symptoms come together. So most of the time, once anybody is having a depressive disorder, they may at least have one of them at the background. Whilst the other things like the weight loss and things comes to add on to it, the things like the sleeping excessively or not being able to sleep at all may also come in, where the hopelessness may also come in, the suicidality. They are all in the ICD, but they are add-on. They are not core symptoms, but they can also be regarded as complications. Sometimes depression can be complicated by hearing of voices, seeing of visions here and there, and those are hallucinations. And then we say that it's a psychotic kind of a depression, for that matter.
So at what point must a person seek help after going through or exhibiting some of these symptoms? At what point is it urgent for you to seek therapy or medical support?
Okay. So I think that as human beings, we shouldn't even wait for things to get complicated before we start seeking help. But then immediately you notice that you are having some of these symptoms we are talking about. You feel hopeless about life. Your self-esteem is low.
Low.
You are
can't
finding
eat.
it difficult
Yeah.
to even have appetite for food. You can't eat. You are losing weight and stuff like that. And these are affecting your personal life in terms of your productivity level, your family life, your educational life. I think that you should quickly speak to someone about it. Hopefully, even if you do not know, that person can point you in the right direction so that you can receive the necessary help and attention that you need. Yeah.
So, still on the range of symptoms, what are some of the symptoms, especially in regards to pathological? What are some of the symptoms that manifest in the physical body of a person going through depression?
Okay. So, an individual who is going through
Aside the
depression,
psychological, so
depression,
yeah.
we've talked about things like weight loss.
Weight loss, so that's physical.
It's physical. They may lose weight. Sometimes they may have these strange headaches, which we refer to them as somatoform kind of somatization of the symptom, of the psychological symptoms, which often comes like a burning sensation running through the head of the person. Sometimes they will tell you they are having these tingling sensations and fire or heat
In
all
their
over
body.
their bodies and stuff like that. And it seems to not be amenable to normal paracetamol and things that everybody would take.
Experience, yeah.
So sometimes it shows itself in those ways, nervous or neurotic disorders. And then sometimes they even, because of one, the weight loss and the way they neglect their personal hygiene, because of the fatigue, like I said, they lack energy. Often the energy is low, so they don't even want to spend time and energy
bath.
on themselves. And so once you see them, they look disheveled. If it's a lady, they don't even brush their teeth, they don't comb their hair, and they look like dejected. You understand? And so you notice it. Sometimes you may see the person and they are stooped low. They can't even look at your face.
When
They
they
are
are talking
looking
to you.
dull. Sometimes they are staring at the same place all throughout the conversation. And these are all physical things that you can see on the person. They are absent-minded.
Yeah.
You are speaking to them and it's like they don't seem to remember some of the conversations that you've had. Memory lapses here and there. These are things you can obviously notice and possibly draw their attention
So
to.
these symptoms, the psychological and the pathological, so do they manifest simultaneously in a person where you are exhibiting physical manifestation and in your mind or you're thinking to they have a lot of disorders, hallucinations and all the things you mentioned? Do you experience these in isolation or you experience all these at the same time?
Well, funny enough, it can be it can all be present in the same person.
Yeah.
Unfortunately,
But where does it start from?
unfortunately, it can be all be present in a person. But then, of course, it can also be one or two symptoms,
Okay.
but of such severity or intensity that it is leading to an impairment in the person's life, for that matter. Now, I'm saying that, or I want to emphasize that, so that we don't think that, okay, everything should be present before we think we are not well.
Yeah.
Sometimes it is just one or two of these symptoms that we are talking about, and
Yeah.
they can be that
Severe.
that you need to rush and quickly get attention, for that matter. But often it will start off slowly with these irregular thoughts, but everybody's own is different. Sometimes they are demeaning thoughts that we say to ourselves, but we are saying it unconsciously.
Nothing will come out of you.
Exactly. You are worthless. Who do you think you are? Take a look at all your friends. They have made it in life. You took this decision, and look at where you find yourself. You recognize that these things are coming from you as a person. They are your own thoughts, but you keep telling yourself these thoughts over and over again, and at a point in time, your mind accepts it as the truth.
Yeah.
And now it starts behaving as if that is who you are.
Your reality. Yeah.
Exactly. These are things we call cognitive distortions.
Yeah.
That sometimes we even try to address when it comes to therapy, to realign it for the person to feel better and start thinking correctly about themselves. Yeah.
So I'll take you back for you to emphasize on specifically the types of depression that you look at the hospital.
The psychiatric hospital.
Yeah.
Okay. So there are different types of depression. Depression itself, in terms of severity, we can have mild, moderate, we can have severe depression, for that matter. But then when it comes to the various types of it, there's the psychotic depression, which I mentioned, whereby depression is laced with some psychosis, like hearing of voices, seeing of visions, delusions for that matter, may also be part of the psychosis itself. Then we can have depression occurring as part of bipolar affective disorder, whereby the person has one pole, which is the manic pole, whereby they are high and mighty, their energy is so high, and then at another pole, they are so low, they are so down, they are so sad most of the time. That is the depressive pole when it comes to bipolar, for that matter. Then there is the recurrent depression, which is just like the same depression, just that it seems to happen in short episodes. It happens 2 months, it goes. Then after a week or two, it comes back again. It happens multiple times. Okay, we have something we call rapid cycling kind of depression or a recurrent depression, and it happens more than 4 times in a year. Okay, then we have the atypical depression. Now, the atypical kind of depression is that under normal circumstances, when someone is depressed, they do not sleep.
Yeah.
They may not be eating well. But in the atypical kind of depression, they rather sleep a lot and they eat a lot. So instead of losing weight, they rather keep gaining some kind of
and they
weight.
are not even aware.
They are not aware of it. Okay.
You just love food.
Exactly. You know.
Okay.
And they are eating. That is, it's more like a way they are coping with the symptoms that they have, and so they tend to just munch on anything that's
available to them,
that they grab. And they don't process the caloric intake that they are having at a particular point in time. Sometimes too, it's just because of the fact that they are not moving much, so they eat and they sleep. They eat and they are just back to bed. So of course, once you are not burning calories, you accumulate it.
You gain.
And therefore they gain a lot of weight in that particular. That is atypical kind of depression. Yeah. Then there is the seasonal affective disorder, which often happens with foreigners or in the Western world, where they have extremes of the weather here and there. So when there is winter, everybody is indoors, and when is it autumn or spring, their light system, they don't have a lot of sunlight, so there's often a lot of darkness.
It rains a lot.
Exactly. So usually people also experience some symptoms of depression within that period, and for that one, the treatment is quite easy. Just get them some good amount of light, and they are okay for quite a bit. And so those who know it, they prepare themselves when those seasons are about to hit, and then they feel better. But then, having said that, depression can also occur secondary to physical illnesses. So somebody can have a stroke and have depression.
Out of the stroke.
As out of the stroke. Someone can have a heart failure and have depression.
Yeah.
For that matter, somebody can have a spine injury and they suffer depression.
Yeah.
And that is very, very important. So depression sort of underlie some and quite a lot of our physical health conditions that we are seeing even in the general medical setting, for that matter. You understand? And it's something we often don't pay attention to as clinicians. We are just interested in the big things, you know. The person has heart failure, let me manage the person to get well and all that, but forgetting how they think or mentally, it's that cool condition of the disease is affecting their minds.
Okay, so I want to know the rapid cycling depression that kind of comes in cycles. Is it to say that certain kind of people, race or gender, are much more susceptible to depression than others, or in other ways, can depression be linked to genetics?
Yes.
Or hereditary?
Yes. So there is a good amount of evidence to show that quite a good number of people experience depression because they are related to someone who has had depressive symptoms in the past. Okay, I think that the percentages range from about 30% to almost 60%, if I'm not mistaken. Okay, so genetics play a very crucial role when it comes to depressive disorders, as well as even anxiety disorders, for that matter. So as for in the clinic, when we are seeing people with depressive disorder, we always want to go back into your past and
history.
find out, is there any family person, is there any first degree relative who might have suffered from a similar thing. Sometimes it went unnoticed. They just felt like, oh, he or she just doesn't like talking, but it was a depression. They felt like, oh, he just died. So we go into the details or even finding out whether there is anyone who might have committed suicide in the past. Did somebody in the family get missing? And we never found the person again. All these things are telltale signs that we may or might have someone within the family who suffered a depressive disorder.
And then also, I heard for the first time depersonalization, derealization disorder in Paul's issue. The young man who wrote to us, who sent us a letter from somewhere in the Western region. Is it a different form of depression? Where will you attribute depersonalization, derealization?
So depersonalization, derealization, it's not really a disorder on its own. Okay. It's part of the symptomatology. It's part of the manifestation of quite a number of the disorders in mental health. And for that matter, once depersonalization or derealization occurs, then it means that the disease is taking a severe turn. Okay, so if it is depression, it can happen in depression, it can happen in anxiety, it can also happen in psychotic disorders as well. Okay, but once it happens, then it means that the disease is taking a very severe turn at the end of the day, and you need to pay rapt attention to it. It simply refers to the individual feeling as though they are spectators in terms of what is going on around them. So they feel like either the world that they find themselves in is not real. It's just like a stage. It's somebody's acting things out.
So they sit back and it's like they see their life being played to them.
Being played. It's more like
in an imaginary way.
So it's not imaginary, it's real.
So they see it real.
They see it real happening like this, as though we are sitting at this interview. So I see it real. I'm partaking in it, but I see it like it's an act. It's an act. It's not tangible. It's not really it hasn't happened.
Yeah.
Do you understand?
Yeah. It's
Or
false. It's
yeah,
not
it's
true.
false,
Yeah.
exactly. Or even me myself, what is the proof that this is really me
Yeah.
over here?
Yeah.
It's just that my mind is putting a picture in place to show this to me as me, because maybe tomorrow I will look like me. I will not look like the way I'm looking
Yeah.
at the moment. So it's like they are out of themselves and they are only spectators when it comes to everything happening
So
around
for
them.
such a person, what's the way out for him?
Yeah. So usually for such people, you need to tackle the condition from the basis.
Yeah.
Identify the ground cause or the root cause. And once you identify the root cause and manage the root cause, all these symptoms will resolve subsequently. Okay. That is where you need somebody who is well trained to be able to actually handle some of these things when it gets there, because the management or the treatment is multifaceted. We use an approach we call a biopsycho social kind of approach. Sometimes we even add spiritual treatment to managing some of these things.
Spiritual treatment, as in the case of prayers or anything the person believes in.
Yeah, it could be anything the person. It could be meditation.
Meditation. Yeah.
It could be reading the Bible.
Yeah.
It's a matter of what the person has built over the years
Okay.
as something they believe in,
Yeah.
that we can work with.
Okay.
And once that is identified, it is infused into the therapy and we get the needed outcome.
And another common kind of depression, I don't know if you situate it in any of the major depression types or depressive types you mentioned. Postpartum depression.
Yeah.
It's also very, very common in our setting. A lot
Yeah.
of women experience postpartum depression.
Yeah. I didn't mention that one.
So it's a
quite,
type of depression.
It's also a type of depression, but it's
Okay.
peculiar to women.
Why is that so?
Because it often happens within the peripartum period, either whilst they are pregnant or after a year after they deliver. Okay, so that period is a time where women are often very vulnerable to these kind of disorders, and the vulnerability is primarily because of the stress that the period comes with, the pain that they anticipate they are going to have in labor, the disfiguring appearance they have. You know how they often
Their body
like to
change,
look,
yeah.
the body changes, they are looking at themselves in the mirror and are saying, really, is this me? You know, the kind of assistance or help they may get from other people who are around them, which is the social support in taking care of the newborn. It all adds up to the stress, the sleepless nights. It all adds up to the stress, and then psychologically modifies them into now starting to manifest the symptoms.
Yeah,
Yeah.
so just on record, a man can never experience postpartum depression,
No.
especially if the man has been deeply associated with the pregnancy journey, being at the ward with the wife, seen her deliver, and post-delivery, the man is also involved with all the stress and everything.
Oh, a man can have depression
But
of
not
their own, but we won't call it postpartum kind of depression, you know. Yeah, and yes, a lot of men do experience it as well, because you've had all the attention from your wife, and now this little one has come by and it's occupying your wife throughout, taking all her time, you know. And so some men also feel down, they get blues over time, and if you don't handle it well, you can even get depressed, you know. Yeah, it happens. There is another kind of depression that happens around the time that ladies have their menstrual periods.
Oh, okay.
Which is the menstrual dysphoric syndrome. So sometimes they
Do
can
women, a lot of women know about this?
Oh, well,
They only say, from what I know, that it's mood swings, or my mood has changed because I'm menstruating. But
they
it's
are
a
aware.
form of depression.
Yes, yeah. It's a dysphoria. It's a dysphoria. They become very irritable, and it's more like somebody who is very tight with you. You're going to ask a simple question, and they give you a very big cheeky answer, and you're like, "What did I do to her?" You know. So it's also something that is very common, and they go through it every time.
Is this different from what they experience during ovulation too?
I think it's slightly similar. They are similar to each other. You know, it's the hormonal imbalances. Estrogen is here, progesterone is here today, tomorrow is here, and Charlie, why am I bleeding at all?
Yeah.
And they feel like, hey, don't touch me. You know, that kind of thing. So yeah, it's also something very common around us that if you pay attention, you know when to ask for what you need from them at any particular point in time.
Okay. All right. So, Doc, is this the same as premenstrual syndrome?
Yeah, premenstrual syndrome is what we refer to as the menstrual dysphoric.
Oh, okay. So it's the same.
Yeah.
Oh, okay.
Yeah.
Now let's come back to mental health in general. Are there lifestyle changes we can all make to sort of increase our mental health resilience baseline? Because mental health is a big thing that has to be taken serious. Are there lifestyle changes you will advise?
Yeah, there are so many things that we can do on our own that can improve and enhance our mental well-being, and they are not anything new or different. It doesn't cost much. Things like eating healthily, making sure that your diet is well balanced. I know that you say that we are in hard times, so sometimes people don't even get the money to even get a
we're
good
always
meal.
calculating.
You know, but you see, I always say that it's often not even about the quantity per se, but the quality. It's a mix that you eat. If you get the right mix of nutrients, you'll be healthier than eating in bulk. You'll be healthier than the person who eats a huge muscle of food, all the same. And things like regular exercising. Exercising has this benefit of releasing endorphins into our system, into our bodies. And these endorphins are natural opioids. They are within us. And they go to stimulate certain parts of our brain to make us feel happy, to make us feel fulfilled. So exercise has a way of boosting your self-esteem. You can imagine you go to the gym 1 or 2 times. By the time you come back, all your muscles are looking swollen up and you are feeling good. Hey, today you see how you walk. Your walk even changes all of a sudden just because you were able to meet certain targets at the gym, you know. So exercising, eating healthily. And I say that we are blessed as a people that we live in a society that cares about each other. And so I encourage people to socialize with the right kind of people. Go to church if church is where you find some form of
joy or
happiness. Attend meetings, gatherings. Don't isolate yourself when your friends are meeting together, but choose the kind of friends that you are going to have and have healthy conversations for that matter. It's also one thing if you start associating yourself entirely with people who are indulging in drugs and alcohol abuse and all that. But if you are careful in the choice of friends that you are making, that goes a long way to help you. Then I also ask people to practice mindfulness. Mindfulness simply refers to getting in touch with your spirituality, the spiritual self, meditation.
That's what I do.
You do
every morning. I do meditation.
It's so important. It is so important. You know, it's not the preserve of a few people. It's something that we should all practice.
I do it.
Get some positive words and meditate on those
affirmations. To yourself.
Say those things. Let it be imbibed into your being as a person, so that Even when you are unconscious, that unconscious part of you will start speaking good things to you at the end of the day. And all these things go a very long way to build resilience. You can also have things like mentorships. Mentorship, get someone you trust who you have vetted very well to mentor you, to guide you, to keep you straightened up, and you will never feel alone at every point in time. And lastly, one thing I want to say is that talk and seek for help when you find yourself in any crisis situation.
Who should you talk to?
Speak to anybody, at least for a start, until you identify the person who can help you. It is better to speak up than suffer in silence, because there is actually help available for everything that we are going through in life, and you are never alone, irrespective of the problem that you think you are facing at any point in time. You understand? So speaking, talking, just using your voice, it's so important. It's so important, which also means that when we are also around people, we need to be paying attention. Let's pay attention to what they are saying. Let's not take people for granted that, oh, all this thing you are saying is just nonsense. No. No.
We tend to just throw it away, brush it aside, that, oh, this one. And some people even say that if you get money, you get some money hitting your bank account, you'll be fine. That's all you need.
No. That's not true. That's not true. We joke and trivialize people's genuine concerns that they may say. So there are cues that we should be picking as individuals when we are around our friends, for that matter, by listening as well. And these things will help to improve our mental well-being and resilience.
At some point, when I was going through my depression episode, my doctor asked me if I had a girlfriend. Then this was somewhere in 2013. I said yes, and he asked me to go and have sex. So how important, or what is the role of, and let me qualify sex, responsible sex.
Okay.
In especially you've mentioned is it
endorphins?
Endorphins. Yeah. And sex also stimulates endorphins.
Exactly, yes. So sex has a similar effect to exercising, actually. So endorphins, like I mentioned, they are naturally occurring opiates in our body. Okay, and these things, they go and stimulate parts of the brain that, for instance, when you are happy, the dopamine goes to stimulate those areas so that you want to continue to have the same. And sex has that effect, for that matter.
Responsible sex.
It releases endorphins that, of course, make you feel happy and fulfilled, relaxed, and all that. But the funny thing is that when sometimes you are depressed, even the appetite to go and have sex does not exist. Now that brings me to that third core symptom, or core feature of depression: the lack of interest. The lack of interest. I told you that I've forgotten, but it's because it was captured somewhere else in the story. But the lack of interest in sex can be a core feature when somebody is depressed, to the point that they will not even get an erection, less to talk of even thinking of engaging or initiating the activity. Sometimes sex only becomes dutiful to such people in marriages. So once you are having partner like that whose interest seems to be doing, I think you should now start inquiring what is really happening. It's not all the time that it's because he or she is cheating or has someone else. Maybe they may not be psychologically well. You should seek some form of counseling and advice here and there.
Aside Pantang, aside Ankaful, can anyone walk into any medical facility to seek mental health therapy? Do all hospitals have mental health departments people can just walk in to seek help?
I so wish I could say yes. Ideally, that should be the case, that there should be a mental health unit, or you should be able to walk into any health facility and get access to mental health care. The Mental Health Act, Act 846 of Ghana, of 2012, actually makes provision that every district hospital, every regional hospital should have a psychiatric unit,
Yeah.
which is often manned by at least a community psychiatric nurse who
Yeah.
can actually offer some form of first aid to anybody in mental health crisis, for that matter. Apart from that, there are a few private hospitals, often in Accra and Kumasi, who also offer mental health care services to individuals. But unfortunately, most of the hospitals do not have that setting. They don't
Services,
provide
yeah.
that service to their clients, and it's sad.
So the major ones are only Pantang and Ankaful.
As it
in
stands
Ghana.
now, yes, there are only 3 major tertiary psychiatric hospitals: Ankaful Psychiatric Hospital, Pantan Hospital, and then Accra Psychiatric Hospital.
Yeah.
Unfortunately, they are all in the south. I understand 2 are underway and being constructed, one in the Ashanti region,
Okay.
and then another in Tamale, but they are all yet to become functional and operational. Yeah.
And then I also want you to touch on medication, because a lot of the stories we've heard from people who have had depression, it's also on, they've been put on medications. Some, there are no end times of when they would be taking
The
off medication. At what point does medication become necessary when you do or you assess a mental health or someone who is experiencing depression?
Okay. Specifically for depression, I told you that we grade the severity of depression: mild, moderate, and severe. Per existing guidelines in various parts of the world, for mild forms of depression, often we attempt to use just therapy, meaning talk therapy or psychotherapy, to try to manage the situation, realign people's thinking so that they get out of the depression. But then there are times whereby that alone is not enough, especially once it moves to the moderate level of severity and even major or severe depression. Then we have to add medications to the therapy. Even with the mild, sometimes psychotherapy after a long while it doesn't work. So we now have to reintroduce medications over there. Okay. Once medications have been started, I mentioned earlier on that depression often takes an episodic course. So it means that once it starts, it ultimately can end. Okay. Whether you start the person on medications or not. Now, we medicate people, one, to reduce the severity of the symptoms that they are experiencing, shorten the duration that they are also going through, avoid complications. Okay. So the medications become necessary at a point in time once we realize that red flags are coming up. Okay. Now, we are hoping that the person will be on these medications long enough for that phase or episode to pass. But there are people who, after you withdraw the medication, their symptoms seem to show up very, very quickly. And so for that matter, they may be left on the medications for a longer period of time. So maybe you are meeting those kind of people a lot these days, because the depression seems to have a recurrent nature. You remember I mentioned something like recurrent or rapid cycling kind of depressive disorder. And so for those people, we often want them to remain on the medications for a bit of a longer period of time.
Does it get irritating when you you've had to deal with a mental health patient for a long time, to a point where you feel that they are not doing much or enough for themselves to get out of the situation?
As for me, I've never been irritated by anybody's
Great.
circumstance,
Yeah.
because I rather feel empathy for them,
Yeah.
because I know I feel I could have been anybody for that matter, including me, who is attending to them. I never get irritated by their circumstance. I rather feel their frustration. I feel like they rather should be frustrated or irritated by me every time telling you do this, take
Yeah.
this, and stuff like that. Not rather me being frustrated that
about, yeah.
they are continuing to have their
Yeah.
symptoms at all. No. It hasn't even crossed my mind before.
Yeah.
Nah, not at all. Yeah.
It's been good having you on this conversation, Doc. But before we end the conversation, is there anything you are passionate, any appeal you want to make about mental health, and if you also have any personal call?
Yes. So generally, I want to thank you for this opportunity to come on to this particular podcast. It's been great being here as well. We've had very interesting conversations, and I think this is a good platform to reach out to the youth out there with regards to their mental health issues. But I want to use the opportunity to let people know that help is available.
Yeah.
Mental illness is just a disease. There is no spirit. There's no
demon.
There's no mystery like that behind it.
Why are you looking at me, Celestine?
There's no mystery like that behind it. You understand? And it can be well managed. So people should not keep and bottle up their symptoms to themselves until it gets out of hand. So they shouldn't suffer in silence. They should speak up and get help, because the help is available. We are tired of seeing people at the terminal end of mental illness spectrum before they come to the hospital. We need to start coming up early, and then we nip it in the bud. Okay, yeah. But this one too, on a personal level too, I also
we
want
are coming,
to
Ankaful.
yeah,
us.
appeal to everyone who is listening to us. Ankaful is 60 years.
No, for the records, what's your role at Ankaful?
I'm the acting hospital director
Okay.
at Ankaful Psychiatric Hospital.
Okay.
And this year, Ankaful is 60 years old, and we've got quite a number of things that we want to do for ourselves as a hospital. If I say ourselves, I'm not talking about our own pockets or our own families, but we are thinking about the people who patronize service at Ankaful Psychiatric Hospital, especially those who cannot afford the service. We want to renovate their structures and get them in shape, make them decent enough that they will feel at home whilst living with us. As I speak to you now, we have over 30 to 40 of them who are currently in our custody. And so we are appealing to everyone. Kakre biara nsa, ketwe biara nsa. So anything you have, kindly bring it on board, and we'll be glad and happy to receive you. And we'll put these things, anything you bring to very good use. So that one day, if you and I also find ourselves in the similar position, we will be happy to be admitted at Ankaful Psychiatric Hospital for treatment and management for that matter. Thank you once again. God bless you.
It was a pleasure having you, Doc. Let's do this again.
It's always my pleasure. Thank you.
And all the best.
Thank you so much. Thank you so
Good
much.
to have you. Thank you.
I can't wait to appear here again.
Yes. Definitely.